So this is Purple Team's morning report. Yay! We're down 2 people, unfortunately. So we'll try and teach you guys what we know.
Hi, good morning, everyone. I'm Devanshi Kajal. I'm one of the interns.
And I'm Ben Booterball. I'm one of the PMR interns.
So let's get started. So the objectives today would be a brief introduction about our patient, the differentials that you guys will be thinking about, more about the patient, hospital course, diagnosis, discussion, and, oh, I'm sorry. Just trying to put this out. Oh yeah, learning points and references that we used. No. Sorry. Okay. Okay. So, 33-year-old female with no significant past medical history presented with lower extremity swelling and facial edema. So what are our differentials? Sure, that is one.
Sorry. Let's go back.
Okay. All right, okay, saw that.
So liver cirrhosis. Versus constipation. That's so concept. So, yeah, it's hard to put our liver cirrhosis on.
Okay, we can make a problem one first.
Oh.
IBC.
Okay. So the differentials that we have right now are nephrotic, AKI, cirrhosis, less likely though, lymphoma causing obstruction of the IVC, is that SBC syndrome? All right. Anything else? Anaphylaxis, sure. Mm-hmm.
Anything else?
Sure. Mixed edema. So hypothyroidism, mixed edema, and other ones.
Okay, got that. Pretty good potential. Ours is pretty broad as well.
So here's some.
So yeah, the differentials that we thought about were CHF, pregnancy, SBC syndrome, anaphylaxis, steroid use, hypothyroidism, myxedema, angioedema, polycythemia vera, domestic abuse, Horner syndrome, Bell's palsy, Whipple's disease, nephrotic, chronic liver disease, venous insufficiency, CKD, and drug-induced, of course, hydralazine, CCBs, gabapentin, burns, sepsis, protein-losing enteropathies, premenstrual edema, RA, and dependent edema. So a wide differential. So more about her history. So the edema was gradual, progressive since 1 week. She noticed first in her feet, mostly at the end of the day, because she was a shift work. She worked at a food joint, so her job required her to stand on her feet for almost the entire day. And it gradually progressed to involve her legs and thighs. She noticed some tightening of her clothes. And a week later, she also noticed facial edema, periorbital, and that's when she decided to come to the hospital. So past history, nothing significant, just a tubal ligation, year back, no known allergies. Family history was significant for recurrent renal stones in her aunt, as she wasn't sure of the pathology. Hypertension in parents and sister, who's 25 years old, but no nephrotic-like picture in her. Personal history, she drinks alcohol about twice a month, but denied smoking or recreational drug use. She works at Hardee's on her feet all day. Obstetric history, she's para-3, Life2A1, all vaginal deliveries, no history of any complications during pregnancies, preeclampsias, or renal disease or anything. The other thing that she reported positive was her urine to be more bubbly lately, but no burning or urgency, no hematuria, just some generalized weakness. She denied shortness of breath, cough, fevers, chills, tightness in her throat. No recent history of URIs, sore throat, denied any rashes, joint pains. She was not taking any medications, just took an appetite stimulant. I don't remember the name, but she took it for like 2 weeks some months ago. But we checked. Yeah. Right. And we looked it up. It didn't cause any renal or liver symptoms. It wasn't FDA approved. She called it an appetite stimulant, but it had a bunch of like B-complex vitamins. Yeah, but not FDA approved. Right. She was trying to gain weight. She's 33. No. Right, so let's see. Exam. Constitutional, she's pleasant and cooperative African American female, no acute distress, laying in bed comfortably. Eyes normal, perla, extraocular muscles intact, just some periorbital edema. She's normal Catholic, atraumatic, external ears are normal, moist mucous membranes, no thyromegaly. Chest-wise, clear to auscultation, normal vascular breath sounds, no rails, crackles. S1, S2, she had a systolic murmur over her precordium, 2+ pitting edema, up to the mid-thighs, actually below the knees, I would say. Abdomen was soft, non-tender, non-distended. She's obese, no organomegalies, bowel sounds were heard. Mild flank tenderness over the right side, but no CVA tenderness. Genitourinary, no suprapubic tenderness, musculoskeletal, no gross deformities were noticed. Strength was 5x5, normal tone and bulk. Normal range of motion in all muscle groups. Integumentary, she has some open and closed comedons consistent with acne vulgaris, but no other rashes, no lesions. She's alert-oriented, no focal neurologic deficits, cranial nerves intact. Psychiatric, she's making good eye contact, her normal behavior, normal effect. And we'll have.
So, what are some of the labs that you might want to get for this patient? UA, okay. What would be a great one, the urine spot protein to creatinine ratio. So those are some of the things that we, BNP, yeah, that we ordered. So as you can see, you know, from her CBC, no elevated white counts, stable hemoglobin. We did get a lipid panel just because of her family history and everything else. HDL is really, really high. That should give you a little bit of a clue, along with her total cholesterol being really elevated. Something going on. Her Kim7 panel really is pretty benign. Creatinine is normal, so her kidney function's great. Good electrolyte values. Her calcium's a little low, but her albumin's very low as well. That would be a concern, and maybe helps contribute with her edema. And the rest of her liver enzymes are normal, so that kind of takes out some of the probable liver pathology that we had discussed earlier on our differential. For our hospital course, we also got a UA, which showed 4+ protein and some hyaline counts, a little bit of white blood cells in that. Her pregnancy test was negative, so that with the beta HCG, so that kind of rules out that. Thyroid was normal with her normal TSH, and she had C3 was 187, C4 was 53, and her ANA titer was 1 to 320, which is positive, showing a homogeneous pattern. We ordered some imaging, which was like an ultrasound of the retroperitoneum, which showed some mildly echogenic kidneys with some medical renal disease, and her EKG was sinus tachycardia. So based on what we've kind of, some of the imaging, some of those lab results, do you guys have anything that's really sticking out to you of what this might be? Nephrotic syndrome? Yeah. And so that's what we were leaning as well. We had Nephro come by and see and do a full workup. What was the protein kidney?
The urine protein, more than 2 grams.
Yeah. So the urine protein creatinine ratio was greater than 2 grams, which.
Yeah, the urine protein was more than 2 grams, and the urine protein creatinine ratio was 14, which is significant, comes in the nephrotic range.
So we'll let Maya take it over.
Okay, so we'll discuss it now. I'll go through these pretty quickly because you guys know most of it already. So nephritic versus nephrotic syndrome. At first, you know, we thought that she didn't meet criteria for nephrotic syndrome because when we did the urine protein again, it was 1.4 grams. But based on the original, she qualifies. So for nephritic syndrome, you guys know you have hematuria, RBC CAS. You can have proteinuria, but that's not the main issue. You have salt retention, you're hypertensive, and edematous as well. For nephrotic syndrome, you have the proteinuria, which is 3.5 grams over 24 hours. And then hypoalbuminemia and edema, hyperlipidemia, and lipiduria. So again, for her, you know, she didn't meet the criteria for proteinuria based on just this, but again, patients are individuals, so clinically correlate. So we are going to talk about nephrotic syndrome. So this is a pretty good diagram about kind of what's going on here, back to anatomy and pathology, et cetera. So we have our filtration membrane, which is charged, right, and prevents lipids and proteins from getting through. And then we have our podocytes, which kind of block that as well. And then when you have the podocyte effacement, that allows for, or you have something that attacks the basement membrane, or anything like that. So those two things, if any of those are disrupted, then you will have leakage into your urine. So pathogenesis of this, sorry. So like we talked about, damage to the glomerulocapillary walls, which disrupts the membrane, the filtration barrier, results in proteinuria. This leads to wasting of these things: albumin, coagulation factors, vitamin D binding protein, immunoglobulins, and erythropoietin. Sorry. So specifically for the, okay, keep going, yeah, that's fine. Sorry. So specifically for complications, we like to look for, edema, which is basically the decreased oncotic pressure from the protein loss makes it so that the intravascular volume is low, and that will activate your renin-angiotensin system and the sympathetic nervous system, and vasopressin is secreted, and that will increase your salt and fluid retention. That's going to lead to edema. And also, if you don't have any oncotic pressure, the fluid's going to move to the outside and extravasate. Hypercoagulability, remember we talked about we lose coagulation factors. So particularly the coagulation factors that you lose are protein CNS, which you guys know are basically they're antithrombotic factors. And antithrombin 3 is a big one that you lose also. And then you'll also have elevated serum fibrinogen and lipid levels, which are prothrombotic. Hypovitamin D and hypocalcemia. So remember we talked about losing vitamin D binding hormone, and that will lead to vitamin D deficiency and secondary hyperparathyroidism. And anemia, of course, you lose erythropoietin, and you can also lose transferrin, which is a carrying molecule as well, and that leads to an iron-resistant microcytosis, and as well as, of course, your decreased kidney function is going to result in anemia as well. And you will be immunocompromised because we are losing those immunoglobulins, particularly A and G. Hyperlipidemia. So like we talked about before, you guys all know this, decreased plasma oncotic pressure results in your body wanting to increase that oncotic pressure, and since you can't make proteins that fast and you're running out of them, you make lipids instead. Okay, so this is a Maltese cross. So urine dipstick will show 3 to 4 protein, which is what ours did show. And then the 24-hour urine collection will show greater than 3.5 grams of protein grams of protein a day. And you may also actually see the lipid bodies. And that picture right there is basically what they'll look like. And yeah, they can be in free floating or they can be in a cast. So keep that in mind if you go to, centrifuge that urine. And then you have decreased albumin concentrations, decreased total protein concentration, and hyperlipidemia. So tests that you want to consider. So nephrotic syndrome in adults should never be just like, you should never just focus in on minimal change and that's it, because only about 10% of adults with nephrotic syndrome have minimal change disease. So you have to consider systemic causes. So get an SPEP, UPEP to look at myeloma or amyloidosis, ANA, complements, looking for lupus, hepatitis, of course, and HIV and syphilis and thyroid. So all of those should be worked up to look for a secondary cause. Okay. Other things, so etiology. So we're going to talk about 2 main ones, the FSGS and minimal change disease, but these are important as well for your boards: membranous, membranoproliferative, and diabetic. So first thing we'll talk about is FSGS. So that is, FSGS is about 1/3 of the cases of nephrotic syndrome, and up to a half in African Americans. So half of these actually progress to renal failure in 6 to 8 years. So that's pretty serious. We have to catch it early and treat it. So it has a lot of different etiologies, usually systemic disease. So primary FSGS with no other systemic disease is a apolipo-1 protein gene mutation, and the so this is a gene for type 4 collagen, which is a podocyte protein. And so that since those are damaged or those are not wild type, what all of us have, there's an increased level of permeability. So, and that's that. And then for secondary things like systemic disease, we have some things like obesity, hypertension, chronic urinary reflux can actually damage those podocytes, HIV infection, some certain drug exposures, and then renal overwork injury. Yes, you can actually test for that gene mutation, but again, you definitely want to rule out the systemic cause first. Yes, you have to do all of it. So there's only a small amount that's primary. I think it's up to, it's like 10, 20% maybe. But 10, 20% of the already low percentage. And then FSGS, again, on light microscopy, you'll see focal segments of scarred glomeruli. And that has to be less than 50%, because if you have greater than 50%, guys, what do you think it is if it's greater than 50%? It's diffuse, correct. So, so by immunofluorescence microscopy, there's no evidence of immune complex deposition. And by electron microscopy, you do have the process of effacement, but again, no immune complex. And so this is what you'll see on the image. So that's it. And so next is minimal change. So you guys know this. It occurs following a URI or a systemic infection, is usually sudden onset, and it can be primary or secondary, associated with drugs, neoplasm infections, and often associated with allergies. So even though you diagnose somebody with minimal change disease, that does not mean that they don't have an underlying etiology that caused their minimal change. So microscopic hematuria is also pretty common in minimal change disease, and AKI can also occur. So this is definitely less common in adults, and you need it by biopsy. In children, you can, nobody's meant these. Yeah, in children, you can just assume that it's minimal change and go ahead and diagnose that. But for adults, you need a biopsy. So diagnosis is based on electron microscopy and histological features with foot process effacement. So this is what you'll see. So that's normal, the first picture. And you'll see the podocytes on the electron microscopy, and they're separated. And then in minimal change disease, the bottom picture shows that those are fused, actually. So they don't filter anything. Well, so treatment for both of these things, you want to give them a diuretic for edema, but of course be careful if they're intravascularly depleted. So ACEs and ARBs, you only give it to them if they have proteinuria, hypertension, and mentioned below as well. So for primary FSGS, you want to do prednisone 1 mg per kg per day with a max dose of 80. So if somebody's 100 kilograms, don't give them 100. Only give them 80. So prednisone 1 mg per kg for 4 to 16 weeks. So it's pretty prolonged course And then you run into problems because you're like, is this edema from the chronic steroids that I'm giving this person, or is it refractory? So you actually do have to intervally follow their proteinuria. And then for refractory primary FSGS, you can give calcineurin inhibitors and mycophenolate. And then kidney transplant if they have a high risk of recurrence. And then for high risk of recurrence, what they define this as is if you don't have complete remission after, say, 6 weeks. Complete remission is the proteinuria levels completely disappearing. So if they don't have that, if they have only partial remission or there's not responders, then kidney transplant is probably going to be in the future for this person. Secondary FSGS, obviously, treat the underlying cause. Minimal choice disease. So for minimal choice disease, the treatment of choice is prednisone, and you give prednisone until you have a complete remission. And then it can actually take about 3 to 4 months to remit. So don't give up. Always remember that you need a longer course for adults than you do for children. And the statins, diuretics, ACE and ARBs, only if they're hypertensive or hyperlipidemic. For relapsed minimal change disease, we typically don't do that many. A lot of experts even say just retry them on prednisone. If that fails, if they're non-responders to steroids, then you can do cyclophosphamide. If they have any contraindications to steroids, do cyclophosphamide. If that doesn't work, cyclosporin, and then finally rituximab. So obviously, we probably won't be dealing with any of that, but just remember prednisone. That's that. So lastly, we have a, and it's, yeah. It is genetic. No, that's true. So then for those primary people, I mean, kidney transplant is usually what happens, but but they still say you should try steroids first for those people too. Right. And then if I get steroids, you're asking what's the point of doing steroids? That right. It is. It's like a type 4 collagen defect. So I'm not sure why they recommend steroids for primary too. That's a good question, but that is what they say. So fortunately, I don't know, but renal transplant sounds like it would be the depends on the etiology, but yeah. He's usually here, but he was working nights, I believe. So yeah, steroids for everything. So vignette. Lastly, we have a 38-year-old Black HIV positive man presents to the ER with history of malaise, nausea, poor appetite for the last 3 months. He has been poorly complying with his antiretrovirals for the last 2 years. Physical exam shows that he's emaciated, pitting edema of both lower extremities, rated as 1+. Urinalysis reveals red blood cells, white blood cells, marked proteinuria. Right. The answer is FSGS. Good job, everyone. membranous. And that is all. So, yeah. So we actually don't have the full biopsy back, but she just got discharged like 2 days ago.